largest outbreak that we have in the regions. Next. When we look at the Ebola outbreak in Africa, the Bundibugyo, this is the third Bundibugyo outbreak that Africa has ever recorded, after Uganda in 2007 and the DRC in 2012. But the scales of this outbreak now is unlike anything we have seen for this species, Bundibugyo. The two earlier events together caused roughly 200 cases. And the current outbreak, as of 24th of August, has already surpassed 5,600 cases. In the broader family of Ebola outbreak, only West Africa in 2014 and 2016 was larger. So we are, in effect, facing the largest Bundibugyo outbreak in history. Next. So the first signal appeared in early March, and cluster of death initially assessed as measles, as malaria, or other fevers. Testing was negative for Ebola Zaire species. So it took until 15th of May for sequencing to confirm Bundibugyo virus and trigger the official declaration in Uganda and DRC the same day. And Uganda that day also reported its first imported case almost immediately. And WHO determined the event as a public health emergency of international concern. Sequencing data tell us that the virus was circulating well before we confirm it, sometimes around February. And some anthropological data even say that it was there in December 2025. Next slide. So as of 24th of August, the Democratic Republic of the Congo has reported 5,665 confirmed cases and 2,715 deaths, with a case fatality ratio of approximately 48%. Uganda has contained its outbreak with 20 confirmed cases, while one imported case was reported in France. The immediate challenge, therefore, remains the very large and geographically expanding outbreak in the Democratic Republic of the Congo. Next slide. Today, 26th of August, marked the 42nd day since the last confirmed case was discharged from the treatment center in Uganda. That means 2 full incubation cycles, making sure that no more residual risk of Ebola is in the country and making the end of the outbreak in Uganda. Can we applaud Uganda? Next slide, please. So now let's focus on DRC. In DRC, we have 6 provinces and 58 health zones are now affected. For those who are not familiar with DRC, a health zone can be larger than my country. I'm from Haiti. My country is only 26 kilometers square. And in DRC, one health zone can be bigger. And the health zone is the administrative division of the health sector. It is important to note also that we have good news in this outbreak. 1,245 patients have recovered from this outbreak. And however, Ituri, the province of Ituri, carries the overwhelming burden with over 4,700 cases. Next slide. Geographically, this outbreak is heavily concentrated. In Ituri province alone, as I already mentioned, accounts for 84% of cumulative cases and 78% of deaths, with nearly 8 in 10 of his health zone is already affected. Next slide. This is the epicurve. I mean, there's a special evolution of the outbreak. This shows you how daily and weekly the outbreak is evolving. We can see in that graph that transmission remains very active, and the recent weeks reflect both ongoing spread And here, the message I want you to have is that we have slowed the acceleration, but we have not yet bent this curve. That is the task that we have ahead altogether. Next slide. This map shows why this outbreak cannot be treated as a purely national event. The affected zone sit astride major mobility corridors. Mining routes, trade roads, and cross-border movement toward Uganda, South Sudan, and Central African Republic. People move and the virus moves with them. Every corridor you can see in this map here is a potential export pathway. Managing transmission, therefore, means managing movements, screening at point of entry, and coordinating across borders. Next slide. The demographic matters also. Who are the most infected? We can see the most affected group is the working age adults, 18 to 49 years old. Women represent 53% of reported cases. Most are striking and most painful, children under 5 have the highest case fatality ratio, and around 60%. This pattern shapes our clinical priorities. Pediatric care is highly needed, maternal services, and they remind us that this virus is hitting the most vulnerable population. Next. This slide breaks what I just said. This is the fatality down by age and sex. While females are the most affected in this outbreak, males are dying more in this outbreak. You can see that females are dying at 35.2% and male at 40.8%. So the pattern is really consistent of what I said before. The very young, as you can see, in place, the older age group carry the heaviest fatality. Children under 5 are dying at 69.5%. Next slide. This slide is, for me, the single most important operational slide. It is a high proportion. First of all, in blue, you have the death in community, and in green, you have the death in the ETU, in the Ebola treatment units. You can see that there is a high proportion of deaths are occurring in the community, not in our treatment center. When people die at home, they were not isolated, their contact were not traced, and unsafe burial can seed new chain of transmission. That means community deaths are both a measure of where are we failing to reach people early, and also a driver of continued spread in the community. Next slide. We have the key risk drivers. The bottom line I want you, Excellencies, Honorable Minister, to take from this section is the response is not struggling because of any one factor, because of one single factor. We have a combination of those factors. First, the hazard itself. It's very serious, often fatal virus with no vaccine or specific treatment. Second, delay in detection. I just informed you that the virus has been there since February, and we
strategically decided to invest in a sustainable manner in preparedness rather than response. Given the current Ebola outbreak, or in view of it, our country has activated its national alert and preparedness mechanism under the aegis of the government. A certain number of priority measures were implemented, such as the immediate heightening of epidemiological surveillance on the national territory, campaigns towards the population, also organized simulation exercises in order to test our response capacity. Our priority remains sustainable capacity building at the national level, and that is why we are strengthening rapid intervention teams, working on also establishing a national emergency team. There's also training of health staff. Emergency logistics are being strengthened. health surveillance, modern analysis tools for risks are an asset in order to reach our goal, which is early detection, being able to decide quickly and to act more effectively. We would like to commend WHO for its crucial role in this response, and we'd like to thank the various partners and countries for their support. And Cote d'Ivoire is actually part of those who contributed to the tune of $2 million to Africa CDC. Thank you.
Kenya
has the floor. Togo prepares.
Honorable Chair, Kenya thanks the WHO for this special briefing session on the ongoing Ebola virus disease outbreak in the Democratic Republic of Congo. Since the declaration of the ongoing outbreak, Kenya has not recorded a case. However, we fully acknowledge that due to high cross-border movement, trade and population mobility within the region, Kenya is at risk of importation of the disease. In view of this, we have initiated and continue to implement various preparedness measures, including activation of our National Public Health Operations Center, as well as the 26 subnational level emergency operation centers to support structured coordination of preparedness interventions. We have also activated an incident management system, screened more than 487,000 travelers across 26 points of entry. We have heightened our surveillance for the disease since the outbreak began, leading to investigation of 206 alerts. Samples collected following investigation of these alerts have been tested in 5 designated laboratories and all turned negative for the disease. We have trained more than 3,500 healthcare workers at both national and subnational level, sensitizing them on various components of the disease. We have also heightened risk communication and community engagement. Owing to high cross-border movement and population mobility within the region, Kenya urges all member states to strengthen timely information sharing across the borders to inform timely actions. We congratulate the Republic of Uganda for quickly bringing the outbreak there to a control and stand in solidarity with the Democratic Republic of Congo as we combat this outbreak. Thank you.
Thank you. Togo has the floor. Guinea will go next. Thank you very much, Chair. Togo would like to thank the Secretariat for the brilliant presentation that we have just seen about the current epidemic on the continent. We're mobilizing our national emergency team through sustained support, preparing for the response. We encourage member states with advanced experience in preparation of response to share best practice in terms of governance and continuous training. We urge the member states, other partners, and WHO to help in capacity building, to deploy people across borders so that nobody is left without the requisite capacity in the face of emergencies. Thank you very much.
Merci.
Thank you very much. Guinea has the floor. Congo will follow. Thank you very much, Chair. Ladies and gentlemen, the Republic of Guinea would like to thank WHO for this presentation on the Ebola virus disease situation in the DRC and Uganda. The experience teaches us that preparation is fundamental when we are faced with Ebola. We need to be one step ahead in terms of response. Under the coordination of our Ministry of Health, a number of different measures have been undertaken. Guinea has relaunched the agreement for coordination of emergencies in airport environments. We are strengthening measures in the air transport sector and at points of entry. We've assessed the risks of the epidemic at this level. We've identified capacity building required. The diagnostics teams were employed to help with early detection as required. At the same time, rapid intervention teams have received training in public health emergencies in the hinterland of the country as well, preparing for public health emergencies at all levels. In order to test national capacity, we are planning to engage in a national simulation exercise and cross-border exercise as well at regional level, working with neighboring countries, Liberia, Sierra Leone, and other countries. We are fully aware that preparation requires predictable funding, pre-positioning of inputs and operational capacity. We asked WHO partners and others to support our exercise and to help fill the gap where insufficiencies have been detected in terms of medication, treatment, and others. Thank you.
La parole est au Congo et
Congo, and then the Central African Republic. Chair, ladies and gentlemen. Congo, through me, congratulates the Executive Secretary of the Regional Office of WHO for this very important point on the agenda dedicated to the Bundibugyo Ebola virus. Congo would like to express its solidarity vis-à-vis the DRC that is having to deal with this epidemic, and we would like to applaud the efforts made by the authorities, the communities, and all partners working on the response. Our country has not yet been affected by the Ebola virus. However, our geographic positioning, the borders with the DRC, the mobility across borders, air, river borders, etc., and also border points expose us to a risk of importing the disease. And so we have activated the National Preparedness Mechanism. The National Emergency Center is on alert, and the National Preparation and Response Plan for Ebola has been revised and updated. Surveillance has been strengthened at point of entry, in training, and also at community level. Furthermore, other measures are being undertaken, in particular, control of travelers, tracking of stocks in terms of PPE, and also awareness raising at community level, and also awareness raising in terms of the travelers using French and local languages. We need to ensure capabilities at points of entry, a lack of capacity in terms of training for some public health professionals, and also the need for laboratory capacity in Brazzaville and Pointe Noire. This is why we restate our commitment to strengthening our preparedness and response mechanisms, working with WHO and the member states, as well as our technical and financial partners. Thank you. The Central African Republic has the floor, and then Comoros. Thank you very much, Chair. Regional Director of WHO, ladies and gentlemen, honorable ministers, distinguished delegates. The Central African Republic would like to thank WHO, CDC Africa, and all other partners for the support given to fight the Ebola virus. The Central African Republic is exposed to a very high risk of importing the disease, namely the Bundibugyo strain, because of its geographical proximity to DRC. We share more than 1,600 kilometers of river borders. We have adapted our preparation based on the 12 pillars proposed by the WHO. After the declaration of the epidemic on the 15th of May 2026, the Management Committee was activated at our level. Based on the risk levels, 3 health districts were classified as priority level. Communication risk plans have been updated. 79% of community health workers in high-risk districts have been trained in early detection of EVD. Points of entry have gone from 4 to 50. And we are now also collecting numerical data. We are also collaborating with the Democratic Republic of the Congo. Mobile laboratories have been deployed to the districts closest to the risk areas, namely Umbongo district. High-level efforts are being made also to mobilize resources that will allow us to implement our national plan, preparedness plan. Preparedness against EVD was complicated by an outbreak of cholera, which is why our health minister is not here today. He is on the ground dealing with this outbreak. Thank you.
Merci, RCA.
Thank you very much, Car. Comoros, you have the floor. Thank you very much, Chair. The Comoros would like to thank WHO for having put this EVD issue on the agenda. It is obviously affecting our continent as a whole. The declaration of public health emergency of international concern has led us to take this matter very seriously. Although we do not have borders neighboring with these countries, they're not neighboring countries. However, we do now have more people traveling to our country from all of the countries affected, often trying to get to Europe because we're close to the Reunion and Mayotte. So we are receiving more people passing through from other places in the world, which is why we are preparing for possible importation of the epidemic. And so a number of different meetings have taken place at the level of our government authorities. The Minister of Health, the Minister of Home Affairs, and other units have worked together to come up with a strategy to control migratory flows. A number of different exercises were conducted. We had to review our Ebola management plan. This was updated, and we set up a team that is in charge of managing the first case should one emerge. And we also undertook training of surveillance agents at the borders, and the borders, the official borders now have surveillance because we have porous borders. Clandestine migration is a great concern. We need further strengthening, therefore, at this level. As for challenges, well, the diagnostic element is the biggest challenge. We need diagnostics tests. We have a lack of those. And there's also a matter of PPE, personal protective equipment, specific equipment for EVD. This is what we need to manage cases. Thank you.
Merci.
Thank you very much, distinguished delegate. I see no further requests for the floor from the member states of the region. I invite member states from other regions, UN agencies, and other non-governmental organizations to ask for the floor by raising their nameplates. Thank you. UNICEF, you have the floor. IOM next.
Thank you, Chairperson. UNICEF commends the government of the DRC, WHO, African CDC, partners and communities for their leadership, commitment, and collective effort to contain the Ebola outbreak and protect affected populations. UNICEF would like to emphasize these three key points. The response must continue to protect children and mothers while maintaining access to essential maternal, newborn, and child health services, particularly in the affected and hard-to-reach communities. So the scale and the speed of the response must match the scale of the outbreak. Community trust and engagement are fundamental to controlling Ebola and ensuring people continue to access essential health and non-health services. And lastly, we must continue to learn and strengthen for the future. We must continue to capture and apply lessons from the response to strengthen preparedness, health systems, and community resilience, and reduce the risk and impact of similar outbreaks in the future. Finally, UNICEF remains committed to working alongside the government, WHO, African CDC, partners, and community to protect children and mothers, sustain essential health and non-health services, strengthen community trust, support communities to contain the outbreak, and turn the lessons from this response into stronger preparedness for the future outbreak. Thank you.
Merci.
Thank you very much, UNICEF. The IOM, you have the floor.
Person, as the UN Agency for Migration, IOM recognizes that population mobility is a critical consideration in all outbreak response and preparedness efforts. Migrants, cross-border traders, transport workers, refugees, IDPs, pastoralists, and border communities are often among the first populations exposed to these emerging public health threats, as shared also with member states in this meeting. While they also face major barriers, to this, in support of government-led efforts, IOM has scaled up operations across different countries, which are at risk, as well as those that have been affected, with significant work in DRC, Uganda, South Sudan, Rwanda, Burundi, and other member states. To date, we have mobilized more than 23.6 million USD and provided more than 19.8 million health screenings at 227 points of entry. Through population mobility mapping, IOM is working closely with governments to identify high-risk mobility corridors, congregation points, border communities, and formal and informal crossings where disease transition risks may be elevated. Lastly, IOM remains very committed to working under the leadership of member states and in coordination with WHO and Africa CDC to strengthen POE preparedness, protect migrants and mobile populations to ensure that our continent is safeguarded in this and any other future outbreaks. Thank you.
Gavi, à vous la parole.
Gavi, you have the floor.
Thank you very much, Mr. Chair and Excellency. Gavi stands with the Democratic Republic of Congo, and Gavi stands with the Democratic Republic of Congo and with all countries in the region at risk of Ebola. To support the response, Gavi has mobilized 50 million US dollars. This includes 40 million to accelerate access to potential vaccine against Bundibugyo Ebola virus, and 10 million to help affected countries, including DRC and Uganda, to protect frontline healthcare workers and sustain essential immunization services. Gavi has also invested significantly in regional coordination efforts through support to key partners, including WHO, Africa CDC, and UNICEF. In addition, through the Gavi-funded Ebola vaccine stockpile, more than 70,000 doses of Ervebo have been made available to support studies on cross-protection and the vaccination of frontline health workers. Finally, Gavi remained fully committed to supporting the people of the Democratic Republic of Congo and all countries facing the threat of Ebola. We will continue working alongside government and partners to support response efforts and help ensure that vaccines can contribute to bringing this outbreak to an end. I thank you.
Merci.
Thank you. The International Federation of the Medicines Industry, you have the floor.
Thank you. Marking the 100th day after the Bundibugyo outbreak was declared, the global pharmaceutical industry underscores its commitment and track record to tackling health emergencies. Within a matter of days after the announcement of the outbreak, biotechnology and pharmaceutical companies mobilized along governments, Africa CDC, WHO, CEPI, Gavi, and other partners to develop new vaccines and therapeutics and explore cross-activity from existing ones for the current outbreak. This rapid response demonstrates the willingness of companies to voluntarily contribute to the collective response efforts and the value of years of prior investment in science, platform technologies, partnerships, and preparedness. We see this outbreak as a wake-up call for negotiators discussing the pandemic agreement's PABS annex. We caution that some proposals under discussion could add complexity and cost to the response to to future pandemics and delay access to critical samples and information that scientific research relies on to develop and deliver medicines and vaccines. This will not do anything to strengthen the R&D pipeline either, to improve global preparedness, and will likely lead to fewer companies working on crucial areas of public health during the interpandemic period. We call on the PAP system to strengthen the conditions that encourage company engagement in pandemic preparedness and response, including ensuring timely and open sharing of pathogens and data, legal certainty for researchers and manufacturers, predictable rules, and partnerships that allow science to move forward. A complete version of the statement is available on the IFPMA website. Thank you.
Merci.
Thank you. Thank you for these very valuable comments. Are there any comments from the Secretariat?
Okay. Yeah, merci beaucoup.
Yes, thank you, Chair.
Thank you to all the countries who provide their input and also their appreciation, and also most importantly, what they are doing in order to prepare before they can have a case of outbreak. So regarding the number of partners, I agree that the list is not exhaustive. However, I think I have to make an advocacy for all the donors of the partner that are providing funding to this Ebola outbreak to use the tracking tool, the financing tracking tool that has been provided. It is online and it will be made available to everyone so we can have the information. It is really in terms of transparency, but also in terms of information sharing, so the information can be available and we can also represent it in presentation like this. We really appreciate that, and we will hope that every member state here, we are receiving some funding for this outbreak in terms of preparedness or response, so they can ask them to use the tracking tool so we can monitor those funding adequately. So regarding also the cross-border, I think one of the lessons learned in this outbreak is that a virus doesn't respect borders. So we do not also, think that our border, we can close border. In Africa, we don't have borders. We have population living all over together. They are doing market together. They get married together. They have children cross the border. So administratively, we can say we have borders, but when we look at the way of living of our communities in Africa, we don't have borders. So this is why we are having those MOU or Memorandum of Understanding on how to share information. What kind of information should be shared between countries? The real-time sharing information, how we can make more coordination across borders. So now population don't need to be restricted of movement, but they know where the services are available so they can access to the service. So with that, I would like to invite you to the cross-border side event tomorrow at 7, so we can continue discuss that. We have 11 countries that already come together in order to agree in some of them to review that MOU that can really establish this commitment on how we can work together across those borders. So let me stop there. And we also take note of some countries with the lack of tests of Comor, that we will work together with you to see how we can provide some equipment and also some tests to pre-position those in Comor. And let me say thank you, Mr. Chair, and thank you to all the member states. Thank you to Gavi and all the institutions that are supporting this response in DRC and the preparedness in the high-risk countries. Thank you. Over to you, Mr. Chair.
Merci.
Thank you very much to the Secretariat. The Regional Committee has taken note of the update on the ongoing Ebola virus disease outbreak caused by the Bundibugyo virus. Thank you all for your very important contributions. This concludes our consideration of this agenda item, special session. Thank you.
Thank you.
Distinguished delegates, this concludes our deliberations for today. Before we close today's proceedings, I would like to give the floor to the Secretariat for any announcements or